Thank you for having me here in the department, and this could be possibly one of the most exciting talks that you'll ever hear. I'm thinking that it likely won't be. This is going to be about graduate medical education. I'm the education guy. My name is David Linville, for those of you who don't know me. I know most of you, and I'm the Associate Dean here at the college. We're going to spend a little time today talking about what's new in accreditation. Why things are happening the way they're happening, give you some perspective about what the new curricula look like in GME, not just in OB/GYN, but other programs, sort of the new ways to evaluate people, what's in the pipeline. I'm going to talk a little bit about funding too, because I think a lot of people don't understand where their salaries come from, and the physician shortage, the manpower issue, that's a really big deal right now in GME. So we'll end up with that and take a few questions. So at any point, feel free to stop me if I use some kind of term that you don't understand, because it is kind of like working for the government. Once you get into accreditation, you start using acronyms and things like that. So see if I can make this doodad work. So we're going to talk about education, the money, and quality and safety. All right? And I'm disclosing that I have nothing to disclose because of CME stuff. So this is sort of the basis of graduate medical education, right? So you're a medical student, you graduate, you're good to do one of two things. Go on to residency or find another career. Because you really can't do anything, right? So what we are now is in the position that we have to verify that the resident has demonstrated sufficient competence to enter practice without direct supervision. And the old way used to be the sort of apprenticeship, see one, do one, teach one. And I'm sure that sort of is still in the backs of people's mind today on the wards when you're talking about, let's talk about what we're teaching. But the real key is not really how often you do it, but how well you do it. We're really pushing, not just in education, but in healthcare in general, measurable outcomes. And so it's very important to realize that the structure of medical education, especially in GME, is moving in that direction. So the Acgme, when I talk about that, there's two different bodies currently that accredit programs. You probably heard of the Acgme. That is who accredits your program. Right? So if you graduate from a U.S. medical school with an MD, you're going to go to a residency that is accredited by the Acgme. Now, if you went to an osteopathic school, you have an option currently. You can go to an osteopathic residency program, which is accredited by a different program, or you can come to one of these. We're in the process of looking at the Acgme taking over all a graduate medical accreditation. So the Acgme is this huge organization. It's a nonprofit. It's located in Chicago. They chose Chicago because of peer review laws for the state of Illinois. We're most protective in terms of establishing a program there, or an oversight body. There are currently over 9,000 residency programs in 133 specialties that educate over 117,000 residents. So that's a lot of people that we're talking about. It's a big organization, bigger than the body that accredits medical schools. All right. Windows is not genuine. Oh, that's good. Okay, so the Acgme is made up of different member organizations. You can see the list there. It really sort of has changed in terms of becoming more of a structured environment. So my role as my other title is the designated institutional official. The Acgme requires that we have someone called a DIO for the sponsoring institution. That didn't come into effect until like 1998. Since that time, we've had core competencies introduced in the early 2000s. We had duty hours. You know, when I was a resident, we didn't have duty hours. Right? Now we have duty hours, and those duty hours were modified even 5 years ago. So, we've already talked about that. The way it's structured is the Acgme has 26 different specialty committees. So I was talking to the residents earlier today. There is an OB/GYN Residency Review Committee, an RRC. You may have heard of that. There's one for every specialty. The fellowships fall underneath that core specialty. So if there's a fellowship program, it still reports to that core specialty RRC. There's one for transitional year. That's the only single year program that is accredited independently. So for those that are going to do like radiology or something like that and they need a year of something, you can do a prelim year in medicine, prelim year in surgery, or a transitional year. And then there's the Institutional Review Committee, which is the committee that oversees the sponsoring institutions. So the way it's structured is we have a sponsoring institution, which is the university, that my office oversees. Each program then is separately accredited. But for a program to be accredited, the institution has to be accredited. So the sponsoring institution, we're responsible for your professional, ethical, and personal development. That's kind of what we do. I have to make sure that the educational structure works. So we oversee the accreditation system. We deal with the governing body of oversight at the university for residencies, which is the GMEC. I serve as the chair of that, and then we oversee the programs. And of course, you know, if you're a resident, that in the program there's a program director and a program coordinator that are required to make sure each program runs appropriately. This is probably old news to you, right? Even the medical students know this. Have you seen this before? This is what came about, I guess, in 2002. It is something that I think we're getting better at measuring, and I'll talk about that here in a minute. But you know, there's some soft competencies in there that sometimes are difficult to measure. So about 2 years ago, the Acgme was responding to a couple of different influences at the national level. So you have the Department of Education that is refocusing how accreditation happens, not just in medical and health education, but universities accreditation. So a 10-year cycle for review was necessary. And there's a lot of pressure from the public in terms of accountability and oversight of education of physicians. And I think the focus on outcomes now with the change in health insurance reform, if you want to call it that, and the expectation of patient health and safety in our hospitals and in our clinics. So I think this is part of our public trust response as a profession to show that we are capable of providing independent oversights of our own educational programs. So this new accreditation model is now continuous. So the old model for residencies was you had a 5-year cycle. If you were doing great, the review team would come in, they took a look at you, you'd put all this documentation together, they'd review it, send it to the RRC, and you'd have a few things to work on, and they say, okay, everything looks good, we won't see you for 5 years. What we have now is something called a continuous accreditation model. We have data that are annually submitted to the system, and we have now 10-year cycle lengths. And at the end of that 10-year, we're looking at a self-study. So what happens now, it's much more like when the medical school itself undergoes accreditation with the LCME. There's a self-study period about a year out where committees are formed and you look at things and you try to see where you need to go as a program, building on those 10 years of data that you've been working on. So now, every year, twice a year, milestones are entered for every resident in the Acgme system. The program also answers questions about itself online. There are resident survey data. I'll get into that later, but it all goes into every year a program is looking at itself going, okay, how can we improve? It's almost like quality improvement, continuous quality improvement for education. We have an annual program evaluation that happens every year. The next year, you're going to reflect on last year's action plan, build new action plans, and so at the end of that 10-year cycle, you're going to have a series of action plans and a history of documentation in terms of QI for your educational program. We do the same thing at the institutional level. The other thing that's new with this next accreditation system are these visits called CLEAR, and I'm going to talk a little bit more about that in a minute. That's the Clinical Learning Environment Review. That is a separate accreditation process that currently doesn't impact our institutional accreditation. It's done at the institutional level, but it's a short notice visit where they give you 10 days notice that they're coming in and they're going to look at your programs, all programs at a specific hospital location. So back in October of 2013, we had our visit up at Holston Valley, and I'll share a little bit more about that here in a minute. So this is why we move forward with NAS. So I've already talked about sort of accountability to the public. The idea is that this system is, in theory, supposed to reduce the burden of accreditation. I'm not seeing it yet. If anything, my job has gotten even more complicated, and so has the program directors. The idea is that it will allow good programs to be innovative in how they deliver their curricula, and help or assist programs that need help in terms of meeting the standards. So, like I said, this is really this is the first year that OBGYN is in the NAS in terms of having to report milestones and things like that. So phase 2 program started this year. So this is a very new process. Dr. Walt?
There's absolutely no science behind it.
Correct.
Yeah. And even when science goes contrary, they ignore it.
Correct. Okay. Welcome to education. Yeah, right. So, and I'll sort of provide you some of the explanation of why we're doing what we're doing. And it may or may not make sense. Because basically in the educational literature, you can get pretty much anything to show what you want it to show. And what happens is there are certain factions that are able to present their theory first, and that's what gets adopted. And then a second theory comes along, and then we add to that. And I'll show you an example of that in a minute. So milestones are new. The residents probably all know about this. This is something that's now happening at the medical student level too. So you probably, as medical students, have heard about milestones. The nice thing is the specialty at the national level got together and created the milestones for that specialty. For the medical school, Dr. Olive and his team had to create their own milestones. So you may see some differences or similarities, but the milestones are supposed to be a roadmap to those 6 core competencies, so that each core competency is broken into sort of sub-competencies, and there's sort of a spectrum. It's really just introducing a new Likert scale to be able to say, okay, where does the resident fall along this line? They are not intended to be promotion criteria, like you've got to get so many to get to the next level of training or to be able to graduate. These data are part of this competency-based outcome expectation, so that twice a year when residents have their semi-annual evaluations with their program directors and associate program directors, these milestone data are set by a committee within the program called the Clinical Competency Committee. It's like an education oversight committee. And those data are individually reported to the Acgme on that resident, so that you, as a trainee, will have data where you fall on the milestones tied to you. That's currently being used for accreditation purposes, sort of in aggregate form. But because those data exist individually, at some point the specialty boards may get involved and say, you know, we really want to see your history of data before we're going to let you sit for your boards. I just feel that we're moving in that direction. As I said just a minute ago, each milestone working group was the American Board of Medical Specialties, whichever board, got together with members from program director associations. Each specialty sort of has their own national setup, but they worked on these milestones, and they were introduced last year. This is kind of small on the screen, but I wanted to give you an example of what OBGYN milestones are. So this one is obstetrical technical skills, patient care, okay? And so level 1 is like the low end, and level 5 is exceptional. Residents may not even meet level 5, right? So on level 1, it demonstrates basic surgical principles, including use of universal precautions and aseptic technique. Whereas in level 4, performs complex obstetrical procedures, including, and it lists a bunch of things there. I'll pass this around, that way you can look at it if you want to. But you see the boxes down here. The idea is that you get a number. You fall somewhere on that scale. What this has done, though, from a program perspective, is that programs are having to spend an inordinate amount of time sitting together and saying, okay, where does this resident fall on the spectrum? Especially the first time around. I think one of my programs, it took 45 minutes a resident to be able to put the data together and enter it. So this is a very common, reducing the burden of accreditation, right. This is the next level, and what I was alluding to when I was talking with Dr. Welt. Entrustable professional activities is the next new thing that's coming out. And it's different from milestones. So somebody else in the educational literature decided it would be great if we could just sort of group these things by entrustable professional activities. So an entrustable professional activity in theory is something that a layperson in the public would expect you to be able to do. So a pediatrician, you could say, an EPA would be that this pediatrician can do a newborn exam. That's an expectation. And what are the parts that go into that? This is different from milestones, and it's another layer that unfortunately I'm afraid is coming to how we evaluate residents. This one here is, I took from a journal article in Academic Medicine back, it's been several years ago, but these are EPAs for OBGYN. And so some of the EPAs are entrustable professional activities, the normal delivery, the complicated delivery, care of uncomplicated pregnancies. I mean, and there's a lot that falls into that. So this is another rubric that I'm afraid we're moving towards. Now, what I don't know in GME yet is whether or not this is another layer of evaluation. Our cardiology program has changed their evaluation, monthly evaluations of faculty, of fellows, to reflect EPAs in cardiology that they created. There's some talk at the national level that EPAs may become something that we use when you're transitioning between a medical student and a resident. I don't know how this is going to play out. As you can see, this is old. This is from 2007. It's been around a while, but we just don't know what this means in terms of next step, in terms of evaluating people and trainees. So this is the responsibility of the programs. As I mentioned before, you have to have institutional credit or accreditation. You have to have this continuous dialogue now with the RRC. There are no cycle links, and citations can be assessed by that review committee each time they meet, and you respond to them, and each time they meet, they can come off. So the idea is that you have a continuous dialogue about how your program's doing, as opposed to that sort of 5-year cycle I mentioned earlier, where it's sort of like a biopsy. You come in every 5 years and take a look. These are the trended performance indicators. So these are the data that go into that computer system every year. We call it the annual ADS update. ADS is the Acgme's system. So for the OBGYN program, Dr. Olson has to go in and provide data in ADS about the program, and there are specific questions that they ask about what's happened, changes in the program director or the core faculty who are identified, program characteristics, scholarly activity of both residents and faculty. That's all in that annual update. The Acgme also looks at the board pass rate, so they'll take a 3-year rolling average to kind of get a frame of how well is this program doing with their graduates. Every spring, the residents are surveyed from the Acgme directly about how the program's doing in the areas of faculty, education, supervision, duty hours, etc. So there are both common to all residency programs and then some specialty-specific elements on that survey. There may be case logs. So in OBGYN, obviously, it's a procedure-based, surgical-based program. There are certain procedures that you have to track and log. Faculty survey. Every spring, the faculty, the core faculty, are now surveyed directly by the Acgme. Semi-annual resident evaluation. So twice a year, the resident has to meet with the program director or program leadership. And now the milestones are data that are reviewed. And this clear visit that I'm going to talk about in a minute. The things with the blue boxes are new with NAS. So as that rolled out within the last 2 years, those are new elements. All these other things already existed and were used in the accreditation process before. So we're adding more things or more data for the RRCs to look at to provide this continuous accreditation model. What is the sponsoring institution's responsibility? So what do we have to do? I have to make sure that there is central oversight of the programs. So that before, I think in most places, it was true here, you had sort of a loose confederation of programs. So programs, because they're so different and specialty specific, you had some central oversight, but with this new accreditation system, the expectation is that there is a stronger central presence. So myself and the GMEC, the committee, is responsible for ensuring that programs are supposed to be doing what they're doing in terms of quality improvement in the educational process. We have to provide oversight. We have to provide special reviews inside if we see that a program is having trouble. We'll do that. We have to have an annual institutional review. And I've got to be ready for a wide variety of visits than we used to have. So now, because of this continuous improvement process, all of those performance indicators that I just showed you, if there are some flags that come up because the computer's analyzing it, it'll kick it out and send it to the review committee and say, hey, you might want to look at this program because these performance indicators have changed. And that may mean that the RRC calls the program and says, hey, what's going on? Provide us a written report. It may be, you know, we need to come and see how y'all are doing. So we have sort of focus site visits. We have full site visits, limited visits. There are different kinds of visits that happen on an ongoing basis, and that's in addition to that 10-year cycle visit. The annual institutional review basically is my oversight. So each program has their plans about what they're doing. I have to monitor those things and put those in an aggregate form to be able to say, okay, one of the things that Family Medicine in Bristol is working on is their pediatric clinic numbers. And so I have to make sure that they're doing that. And if there's resources that need to happen, dialogue that needs to happen with the hospital up there, I get involved. So that's sort of what we do in terms of central oversight. Now onto this clinical learning environment review. This is new with NAS, and it's an extension of the public expectation of where medicine is heading in terms of patient safety and quality improvement. And so this is a parallel process that happens in addition to all those program level site visits. This is that short notice visit that I was telling you about. We had our first one in October of 2013 up at Holston Valley. It's where the Acgme calls and says, we're coming in 10 days, you have to be ready. The idea is that there's no preparation to the visit. They just want to see the status of where you are with your clinical learning environment. The CEO of the hospital has to be present both for the initial interview and the exit interview, and I have to be present. Those are the only people that have to be there. Otherwise, they won't come. And the reason we had intended to have our first clear visit here, because we have a more variety of programs here at JCMC and we have our greatest number of residents. Although the CEO of the hospital was not available. Mr. Nicely at the time was out of town. And so I said, well, we can't go there. And they said, let's go to Holston Valley. So when the team comes in, they're looking in these 6 domain areas. So they're looking at patient safety, they're looking at quality improvement, transitions in care, how well are trainees supervised, duty hours. The resident follows duty hours, and it's more than just do you follow duty hours, it's how well does the program manage fatigue. You know, what resources are available to our residents. If you're too tired post-call, do you have a call room that you can go sleep even though you're not on duty? Or is there a cab service that'll get you home if you don't feel safe to drive? Right? And so every program has to think about how they'll do that. Now, what's funny is like when the site visitors are here, they'll get with the residents and say, do you have a fatigue plan? Like if you're too sleepy to drive home, what do you do? Well, I'd call a friend or I'd sleep in the call room. Well, how often do you do that? Well, I've never done that. So that shows that at some level, how good is the oversight of fatigue management at the program level. This is one of those soft areas that I was talking about earlier that there's not really a clear expectation about where we're going to be, but it's one of the things they're looking at. And last is professionalism, and this one's very hard to think about. Right now, I think they're using as a proxy when they ask residents during these site visits, professionalism is, have you been given access to any sort of black market database of board questions? And, I guess, because I was like, where's this question coming from? The only thing I can think of is that it's tied to professionalism. Anyway, so the clear focus points, really what they're interested in seeing is how well is the GME leadership and the faculty integrated with the hospital. So one of the things that happens, you've had these core competencies since the early 2000s in the program. The program has been looking at each resident and trainee saying, okay, they're competent in these 6 areas. The hospital separately has Joint Commission accreditation or some other central accreditation for the hospital to be able to say we can function as a hospital. They have quality improvement metrics. Now, those didn't always overlap. And the goal of this CLEAR program from the accreditation side on our side is saying, we're going to push you together and make you work this out. So they want to see how well we interact with the hospital leadership. How engaged are the residents and fellows, and how are we doing? Okay? I think this is one area where we've got a lot of work to do. The hospitals are certainly going to have their own initiatives in terms of infection control and things like that, but how do we plug trainees into that? How do we plug medical students, residents, and faculty into those systems to make it work? So in the area of patient safety, some of the things they're looking at, and you need to start thinking about as trainees, how do you report an adverse event, a near miss, a patient safety issue? There's a structured way to do that at this hospital. What education do you get on patient safety? Is there a culture of safety here? You know, do you have timeouts in the OR before you start? What does the clinical site do to monitor how well the trainees are engaged in patient safety? Are there any projects in terms of patient safety improvement things that residents or medical students are involved in? Healthcare quality. Do we provide education on quality improvement? You know, do you know what kind of process Mountain States uses? They use a lean process. I'll talk about that just briefly in a minute. How engaged are trainees in QI? Do you plan to study ACT cycles? Are you engaged in root cause analyses when an adverse event happens? How engaged are the faculty? I think one of the things that we're finding in terms of patient safety and quality improvement is that this is new for a lot of our faculty. And how do we teach trainees to do this when we ourselves don't know how to do it? I mean, I'm not a QI expert. I'm becoming one. Just by the nature of what we do in education, we have to know that. Care transitions is another domain. Now, this is not just the checkout. So now you have a very structured checkout time when you're on service, right? You all get together and you say, okay, patient here, these are the things we expect to happen overnight. We need to do this. We have somebody that's post-op. We need this covered, that kind of stuff. How do we handle those handoffs? Are we making sure that those handoffs work? Are we experiencing any problems in communications? Are the faculty overseeing that process and checking periodically to make sure it works? Also, when we have patient transitions, are those happening effectively? So when a patient's in the ED and getting admitted to the floor, are the orders following appropriately? We had an issue up at Holston Valley within the last couple of years where their CPOE, their record or order entry system in the emergency department, did not communicate with the floor. So all of the orders that you put in the ED were gone by the time it got to the floor. And you had to rely on the nursing staff to bring the paper or something. I mean, it was ridiculous, right? So how well do we look at that? When a person's in the unit, intensive care unit, and comes to the floor, what transition of care happens there? You know, do different trainees take care of the patient? A lot of our residency programs follow their patients no matter where they are. So that's not as big an issue. When you get to bigger training programs, sometimes there's a separate team that's in the intensive care unit and a separate team on the floor. How's that transition happen? Supervision. How well are we supervising our trainees? How well do the faculty think we're doing it? How well do the residents think we're doing it? What do other people think? What do the patients think? What about the families and the patient surveys? What about nursing staff, et cetera? Fatigue management, I talked a little bit about this earlier. So how well are we monitoring that? How well are people using the resources available to them? And then lastly, professionalism. You know, is this something that is expected? Do we talk about it? Is it part of our culture? And you know, it's one of those things where you look at all this stuff and you go, whether you're a program director or a faculty member or a resident, a fellow, a student, what do I do with this stuff? How do I get involved? What does it mean to me? And really, each process sort of has a system to think, okay, what you think it is, what it actually is, and what it should be. And how do you use these questions to frame making the improvement? And there are many, many different ways to do this. This is one of the things they're using at the University of Virginia. So my colleague up there, Susan, does a great job as DIO, but with them having a university hospital, it's a little bit different in terms of how they provide their safety. So one of the things they're using with their quality improvement is they're trying to increase things that add value they're trying to minimize things that don't add value, but they know they have to do, and they're trying to eliminate waste. So there's certain things we just have to do, like regulatory items, billing, things like that. They take time, they're not really adding value, but we have to do them. Let's minimize the time that it takes to do that. Let's eliminate things that don't make sense, like extra meetings, extra patient waiting steps. So when a patient comes in for pre-op, you make them wait here, then they go here for 20 minutes, then they go there for 20 minutes, and their lab work was done the day before. And there's a lot that goes into workflows. One of the examples that they use at Virginia, they have now a patient safety rounds every morning. They have it's like a war room. And they talk about everything, and it's interdisciplinary. There are physicians, there's nursing staff, hospital administrators, and even little things. So one of the outpatient clinics that's there at the hospital, I forget which one, there were these rugs where you come up to the window to check in. And they had rugs down because the floor, when it rains, is so slippery. It's like a tile floor or whatever. Well, patients were tripping on the rugs. You know, you were having accidents on the rugs because of the people coming in. And the reason the rugs are there is because when it's wet, you need the rugs. Well, so somebody said, well, why can't we just roll the rugs up? And when it's raining, we roll the rugs out. Brilliant idea, right? But you just couldn't do that. You know, you had to get environmental services on board. Where are we going to put the rugs? Let's roll them up and put them in this closet. Whose responsibility it is to roll the rugs out? I mean, it's things that, you know, you wouldn't even expect in a healthcare environment, but that are what we're going to have to be thinking about as we move forward in terms of quality improvement and patient safety. I mean, it really is amazing. There are different models. You can have a care model, a lean model, one that's called Model for Improvement, which uses plan, do, study, act cycles. FADE, which is focus, analyze, develop, execute, and evaluate. Six Sigma is a different one. Lean is defining value based on what the patient wants, and it maps that value flow to ensure competency of the process. And that's what Mountain States uses. They don't call it lean. They call it VOS, Value Optimization System, VOS. But they use a lean system. The VA also uses a lean system, but they call it lean. And it's very tricky because there is a lot of science behind this, but you know, how do we have the time to become quality improvement experts? And so one of the things that we can do is have expertise in our hospital systems to be able to provide the structure, but for us as healthcare providers to understand how do we fit into that cycle. Okay, if we need to make an improvement on the labor and delivery floor, how can we do that? How do we integrate with the hospital system? So for us as an institution, there are a couple of red zones in that clear process. One is quality improvement and one is patient safety. I think those are the areas where we're having to figure out how do we make this work. And we're struggling. It is not easy because we're still trying to teach people how to be independent practitioners of OB/GYN. It's very difficult to get that curriculum in 4 years and at the same time teach about this and teach about that. So it's a challenge for us. Next step, one of the things that we're doing from a central standpoint is we're asking that residents and fellows be allowed to participate in root cause analyses as appropriate. How they can participate in Mountain State's VOS system, that's their lean system, and resident participation on committees. So we now have residents that are sitting on the highest physician leadership board in Mountain States, which is called the PCCE, which is the Physician Clinical Care Excellence, I forget what it stands for, but it's a system-wide, so it includes physicians from Virginia and Tennessee. They meet once a month, and we now have resident participation on that committee. VOS and surgery, when the new surgery tower, I guess is what they call it, opened, one of our chief residents in the surgery program went through and helped map some of the things that they were looking for in terms of patient workflows. So those are the ways that we can incorporate as training programs into our hospitals. Clinical effectiveness data. This is a challenge for us, not only for our training programs, but for our faculty. What are our length of stays? What other outcome measures are we using in the hospital to see how well we're practicing medicine? Can we drill that down to the trainee level? How efficient are our training programs? Because studies have been shown that sometimes residency programs are actually more efficient than non-teaching programs in terms of inpatient services. So a buddy of mine, the DIO up at Stony Brook in New York, he said their resident teaching teams have much better outcomes than the non-teaching services. But they have those data to review. And right now, we're having trouble with our health system partners providing us data that are meaningful. We're having an ongoing dialogue with Mountain States to improve that. We've made progress at Wilmot to be able to get those data. How do we engage our faculty in these discussions and identifying areas where we can make improvement? Those are our next steps. I alluded to this earlier, but one of the other big things that's happening in GME land as we speak is having a single accreditation system for GME. So as I mentioned before, if you go to an allopathic medical school in the US, you get your MD, you can only go to an Acgme accredited program in order to become a board eligible and board specialized physician. If you graduate from an osteopathic medical school, you're a DO, you have a choice. You can do this track, or you can go to an AOA program. So you can see AOA, they're much smaller. There are about 1,000 programs and nearly 7,000 residents in those programs, whereas this one I said we're over 9,000 programs and 117,000. There's different levels of accountability. I'm not in the AOA world, but I'll tell you that from my understanding and perspective, the standards of accreditation for these programs are not as high as these. Okay? We have had discussion probably for about 3 years at the national level where these organizations, the AOA, the AACOM, which is the Association of the Colleges of Medicine for Osteopathic Medicine, have worked with the Acgme and have come up with a single plan where all GME programs will be accredited singly by the Acgme by 2020. So what's happening is the Acgme used a little stick. Historically, if you graduated from one of these programs, you could be eligible to participate in an Acgme fellowship. After 2016, that will no longer be the case. So what they're allowing, the Acgme is allowing now, is for sponsoring institutions to establish themselves. I think this April is the first time they'll start taking applications. And programs later this summer can apply to become an Acgme program. And by July 1st of 2020, the AOA will no longer accredit any programs. They put the 2016 fellowship rule in place to try and drive people to do it earlier, is the game plan. Now, the interesting thing is the Acgme is not changing any standards at all. Absolutely not. In fact, the only things that are changing in this system is that we're adding a new review committee to those 26 I told you about earlier because there's a specialty in DO medicine that doesn't exist here. We're changing membership of the board. So the governing board of the Acgme will now have DO representation. And if you're a DO program, you now have to find a program director that went to an Acgme program. You're not allowed to have, you can have a co-director that was a DO trained program. But now, so huge, huge shift here. I don't know what it's going to mean. What it will mean for students is that there will be residency programs, like 1,000, that didn't exist to you earlier in terms of being able to apply to. So like currently, there's an orthopedic residency program up at Wellmont in Holston Valley. It's a DO program. If they're successful in getting accreditation, you as medical students would be eligible to apply. The problem is, I don't know that they can meet the standards. And so we're probably going to have many of the DO programs closing down. That's going to be a huge issue. Patty?
I sit on the pre-op executive council committee at our national meeting, and just so happens one of my table mates is the DO representative at pre-op, and he said the exact same thing you're saying here. He does not know how many of the apply.
Yeah. It's a huge, huge unknown.
And most PO programs only run with a program director, they do not have support staff.
Right.
There's also monetary issues involved, not just accreditation.
Oh yeah, it's huge. So that's coming. That's a trend. And then lastly, I want to talk about the money. A lot of you may know this, and I won't dwell on it too much because it gets very detailed, but do you know where resident salaries for the most part come from? They come from Medicare, right? And that was established back in 1965 with the establishment of Medicare. They said they would pay for their fair share of training residents. And so what that means now is that there are two types of funding that hospitals get: direct funding and indirect funding. Direct funding covers the salaries of the residents, the benefits, partial salaries of faculty, overhead of education space, so like, you know, the space upstairs where Tawana is, the computers, the copier, stuff like that. And IME was categorized as an add-on to pay for the increased cost of having trainees, because if you have trainees, they're maybe less efficient. You may have higher acuity of care. The types of patients that you're taking care of in a training program are going to be more complicated. And so this was an add-on to Medicare payments to allow for that increased complexity. Okay? And currently, each hospital has a set number of resident positions that were capped by the Budget Act back in 1997. They're capped at 1996 levels. If you want to hire new residents or expand your programs, you're going to have to find a way to pay for it. So I already talked to you about what DGME is and what it means. And IME is a percentage of the Medicare add-on. So the DRG, which is how things are bundled with Medicare. So when you come in and you have Medicare, the hospital gets paid because you had pneumonia. You get paid for the pneumonia. Doesn't matter how many CT scans or whatever else you did, there's a certain package. And up to 5% of that DRG payment amount, it may be increased as much as 5% because of your IME. Now, this gets tricky because what happens, and medical students probably need to understand this, because there's always this talk about, well, Medicare will only pay for you a certain number of years, which is true. So when you graduate from medical school, you match into a specialty, right? Your program registers you as, okay, I'm starting in OBGYN, let's say, right? OBGYN is a 4-year program. That means you get 4 years of training where Medicare will pay the full amount. If you start in family medicine, you get 3 years, okay? After you finish that, that's called the initial residency period. The hospital will only receive half of the amount for you. So by design, anybody that goes on to fellowship training, the hospital is only getting half of that full-time equivalent. Or if you change specialties. So we have a resident that started in family medicine, did a year there, switched to general surgery. So the last 2 years of his general surgery training, the hospital's only going to get half of that funding. That's what direct medical education, DGME, is. And that PRA is important. So whenever you're changing careers, very savvy programs and hospitals will ask, what's your eligibility? Because they're going to be unwilling to assume liability for transfers when they're not going to get full funding, okay? As I said before, Medicare pays its portion of this amount, okay? So let's say you're a resident now, you're a first year, the per resident amount for JCMC I think is somewhere around $72,000, okay? Because you're in that first year, $72,000 is going to be paid to Mountain States for your position to work here. That's going to cover your salary and benefits. But the hospital doesn't get the entire $72,000. They only get that amount that's based on the number of Medicare patients. So let's say the Medicare patient population of JCMC is 45%. The hospital's going to get 45% of the $72,000. That's all they get. That's for the salaries. Now, for the IME, the percentage of that per case add-on, it's very complicated. I'm not going to dwell on this, but this supposedly is the only rule in the federal record that uses an exponent in terms of funding. and it has to do with bed ratios and the number of interns that you have. But anyway, suffice to say that upwards of maybe 5% additional money goes to a hospital based on that. Combined, the federal government's spending about $15 billion a year on GME funding between DGME and IME. 2/3 of it is IME. Only 1/3 of it is DGME. And most of this is from Medicare, as I said. Some of it is from Medicaid. We do get some funding for Medicaid TennCare here to the College of Medicine, which is a little unique compared to other states. And then there are other entities, so like children's hospital funding. Independent children's hospitals are not going to have Medicare patients. Because the children's hospital is attached here, they're able to get funding for the PEDS residents. But you've got the VA, Department of Defense, some other people that provide GME funding. The issue is funding is currently a target, both in Congress and in the executive branch. The Obama administration has looked at, basically we're paying hospitals to be inefficient with that IME money. When in reality, what the hospitals are doing is using that IME money to pay the resident's salary, because they're only going to get about $35,000 to pay your salary, and your salary is, $48,000 plus benefits. So how do they make it up? They make it up with the IME. The Institute of Medicine just came out with a report. I think that's somewhere on here. Anyway, I'll get to that in a minute. These are the at-risk numbers. The executive branch, the Obama administration, wants to look at a 10% cut over 10 years. So we're looking at nearly $10 billion out of a $15 pool, a $15 billion pool. The issue has to do with this funding of the physician shortage, so workforce. One of the things that, if you ever look at workforce trends in the United States, it's kind of yo-yo-like. There have been projections that we're going to have shortages, and we did. There have been times when we've said we had shortages and we didn't. No one's certain at this point, but the AAMC, which is the body that sort of the parent body of medical schools that grant the MD in the United States, are projecting that we're going to be short 90,000 physicians within 10 years. About half of those in specialties, half in primary care, so about 45,000 primary care physicians. And if we have threats to GME funding, what happens? Those positions go away. So one of the things that's happening right now at Johnson City Medical Center is that we're about 40 positions over our cap. So remember I said the number of residents were capped at 1996 levels. Since that time, Mountain States has funded positions above the cap. Now, since 2008 and the economic downturn that we've had and the declining reimbursement, et cetera, the hospital is no longer willing to pay for those extra slots. And we've actually had to cut positions here in our training programs because the hospital wouldn't fund them, and we have no way as a university to be able to fund those positions. This, combined with that, is a recipe for disaster. And I think advocacy for medical students and residents and young physicians getting out, this is going to be critically important, which is why I wanted to talk to you about it today. There is this, I mentioned just a minute ago, the new report from the Institute of Medicine, which talks about transitioning away from this structure, using some of this money to create a new bureaucracy to oversee funding. So basically, all of the funding now, you take some part of it and make a new bureaucracy, and you still don't have enough money to be able to fund. What you do when I go both to Nashville and to Washington, D.C. to lobby and to talk to people and meet with congressmen and senators and whatnot with the dean, and they're all saying we don't have new money. This is not going to happen. I think from our perspective, one of the things that we need to think about in terms of funding has to be at the state level. So one of the things that the Tennessee Medical Association is working for right now is trying to expand the amount of TennCare money that's available for GME. And there may be an opportunity, since the governor is now looking at his own way of expanding Medicaid, TennCare in the state, we may have some opportunities there. So GME today, sort of in summary, we have a new accreditation system. We've gone through that. It's very highly structured. You have very specific individually reportable requirements. You have outside public interests that are looking at us to make sure we do what we do, and groups that are saying we need to totally revamp how we fund education. There's now a timeline for a single GME accreditor with AOA coming on board, and our funding is at risk. Where will we be tomorrow? We will have a continuous accreditation structure with that highly structured curriculum. I will have many more gray hairs, and we just don't know where we're going to be with our money. And it really is a challenging time. I'm an education guy. That's what I like to do. I like the educational structure. What I've had to become is someone that interacts with senators asking for money. I've had to learn how to be an HR official. So you as residents, your health insurance, we had to bid health insurance this year. We got you dental insurance. How do we do that? How do we, you know, it's amazing what I have to know in this job and how complicated GME is. So that's about as much as I wanted to say. I really appreciate your patience on what could be one of the most boring ground rounds you've ever had, but that gives you some idea about where we are with GME today. And we've got just a couple of minutes. I can answer questions. And Dr. Welt?
One of the complaints that I constantly have about education is how you evaluate the student or how you evaluate the teacher. I'm absolutely completely convinced that students and residents have been given no training whatsoever into how to create a constructive criticism of their professor. And only myself knows how to evaluate a resident, because I went to Duke, so we knew how to do that. But the truth of the matter is there's no standardization. I sit down with my partner and I say, well, this resident's really not doing this. She's wonderful. I've worked with her now for 2 weeks and she's just fantastic. We got completely different opinions about the same individual. And so we actually sit down and work that out between
Sure.
before we turn in an evaluation. But I think there's been a sad underutilization of training in evaluation, because quite frankly, the evaluations I get from residents and students really are not helping me to be a better teacher.
And there's no continued dialogue. That's one of the problems with evaluation. So you as trainees, if you evaluate a program or a faculty member, it's gone. There's no feedback. There's no how is this going. If you have questions, there's no way to do that. And you know, I think it's an area that we really need to look at in terms of faculty development. The problem is, how do you take time out of your curriculum and work schedule to do that? You know, you may be the only person in your department willing to come to a session if we had one on evaluation. It's tough. I mean, it's just like coming to a grand rounds on GME. I mean, who would do that, right? You probably had to. That's why you're here. Patty. Yeah.
But yes, if we could create something within the College of Medicine, I can make it happen.
Yeah. Well, and different perspectives. So what Dr. Welt's going to need as a faculty member is probably different from what a medical student or a resident needs. And so that's the kind of stuff that I want to be able to do. And currently I don't have the time to be able to do that. But we're getting to that point. I just got 2 huge textbooks about evaluation and mentoring troubled trainees. So trainees that are having trouble, how do you put together a mediation plan that works? And this is very challenging in medical education. Other questions, comments? Yes, ma'am. Yes, they would be. That's been our argument. Yeah, it's a very myopic view. So they're very nearsighted in their approach to this, and we're beginning to see pushback from other places. So up at Holston Valley, they've decided, because we've cut so many there, they too ask us to cut positions. They're like, oh, wait a minute, you can't cover the same amount of people with the fewer residents? And we're like, no. And they're like, well, let's talk about it. Because, you know, my argument all along has been, okay, so residents are very inexpensive in terms of the hours that they work, the education that they receive, compared to a mid-level. So some of our research indicates that if we took a surgery resident out of the rotation and you needed someone to cover that, you could hire mid-level providers. Because of the rotation schedule and mid-level providers only working 40 hours a week, you're going to have to hire 3.5 mid-level providers. Mid-level provider makes more than a resident, and it's going to be more expensive for you. But I think they're just now getting to the point of seeing that. I think there are things that education adds to a hospital that is not easily measured, and we have trouble communicating that with the financial people at Mountain States, but we're getting better at doing that. They see the value of having trainees here, both medical students and residents, and the higher level of care that patients receive because of that. So it's very complex and very political. Other questions? Comments? Well, thank you very much. I appreciate your time, and have a great weekend.